patient natin. Okay? Later on, it will develop into henoxion lane purpura. Okay? Now, the initial symptoms include the appearance of purpura, okay, respiratory and GIT symptoms, okay, magkakaroon yan ng purpura, respiratory symptoms, okay. I'm sure you're very familiar with this topic kasi nasa Hematology 2 itong henoxion lane purpura natin, okay, and GIT symptoms, okay. Initial symptoms include the appearance of purpura, respiratory, and GIT symptoms, which may include hemoptysis, okay? Pwedeng mag-suffer from hemoptysis ang patient, okay? And then, whereas to GIT symptoms, pwedeng maka-experience ng hematochezia or melena, the presence of blood, okay? Blood in the feces of a person with henoxion lane purpura, okay? And then renal involvement, okay? Laging tatandaan, renal involvement is said to be the most serious complication of this disorder, okay? Huwag kakalimutan, renal involvement is said to be the most serious complication of this henoxion lane purpura, okay? Renal involvement. Okay, renal involvement, okay, is said to be the most serious case of, or rather most serious complication of henoxion lane purpura. Okay, now this disorder, it is characterized kapag na-involve na ang kidney, it is characterized by mild to heavy proteinuria. Okay, mild to heavy proteinuria. Ano pa? Hematuria also, and the presence of RBC Cas again. Okay? The laboratory findings, or rather the urinalysis findings of henoxion lane purpura is the presence of mild to heavy proteinuria and hematuria with the presence of RBC Cas. Okay? Now, in most cases, some patients naman may undergo complete recovery. Okay? So, generally, lahat naman, or rather mostly of the patient with henoxion lane purpura, nakaka-recover naman yung mga yan. Okay? However, there are also some patients that the patient's condition may progress to a more serious form of glomerulonephritis, and renal failure may also occur. Then next, we have your IgA nephropathy. Okay, your IgA nephropathy class, okay, it is mainly due to immune complexes again. Okay, particularly of IgA immune complexes. It is mainly due to the deposition of this IgA immune complexes, which are deposited again on the glomerular basement membrane. Okay. Now, bakit nagkakaroon ng deposition of this type of immune complexes? Okay? Your IgA nephropathy is actually a complication of a mucosal infection. Okay? Kapag merong mucosal infection ng isang tao, okay? Now, kung iisipin nyo bakit nagkakaroon ng deposition of this type of immune complexes, particularly your IgA, kapag merong mucosal infection ng isang tao, ang pinakatataas na antibody dyan is your IgA type. Okay? Now, because of this excess, okay, excess serum IgA levels, ang mangyayari dyan, it will be deposited in the kidneys or any other parts of the body. Kasi nga, excessive na yung kanilang amount. Okay? So, ang nangyayari, there would be an increased serum levels of IgA, okay, and then the result of which it will be deposited in the kidney or other parts of the body. Okay? Now, the patient may usually present with an episode of macroscopic hematuria. Okay, this would be our laboratory findings. Urinalysis findings, okay, may include macroscopic hematuria following an infection. Okay? Usually class pala your IgA nephropathy, also known as your Berger disease. Okay? Berger disease. Okay, it is very common among the children and the young adults. Okay, now the patient usually present with an episode of macroscopic hematuria with an elevated serum IgA levels. Okay, and then in some cases naman, in most cases, the patient may have complete recovery from this type of disorder. Usually, transient lang naman yan, lalo na kapag merong infection yung isang tao. Now, kapag nag-subside na yan yung infection natin, yung mucosal infection, particularly of respiratory infections, usually nawawala din yung mga symptoms ng IgA nephropathy. However, again, recovery from these symptoms is spontaneous. However, asymptomatic microscopic hematuria and an elevated serum IgA level may remain a lifetime. Okay? So, pwede mo siyang or pwedeng hindi na yan maaalis sa isang patient who suffered from IgA nephropathy. Okay? Now, a gradual progression to chronic glomerulonephritis and renal failure are also seen in most cases of IgA nephropathy. Okay, so pwede rin siyang mag-develop into chronic glomerulonephritis and even renal failure. Then next, we have your minimal change disease, also known as your lipid nephrosis. Also known as your lipid nephrosis. Your minimal change disease, as the name implies, okay, it produces little cellular change in the glomerulus, okay. Your minimal change disease, okay, produces little, okay, or minimal cellular change in the glomerulus. Now, with exception to the damage to the podocytes, okay, ang pinaka-damage dito is the podocytes of the glomerulus, okay, together with the shield of negativity, allowing now for an increased protein filtration, okay, allowing now for an increased protein filtration, okay. Of course, kapag damaged na yung podocytes natin, yung nandun sa glomerular basement membrane barrier, together with the shield of negativity, kapag damaged na yung dalawang yan, of course, mapapass out na lang ang lahat ng proteins sa urine, for instances. Okay, makakalabas na lang easily yung mga proteins natin. Okay, now the patient symptoms include okay, in your minimal change disease, symptoms include the patient usually present with edema. Okay, edema-tus yung patient natin. Then when it comes to urinalysis findings, heavy proteinuria is a classic finding of minimal change disease. Heavy proteinuria together with transient hematuria. Okay, transient hematuria. Heavy proteinuria. Okay. And normal BUN and creatinine. Okay, these are the laboratory findings of consistent with minimal change disease. Again, ano yung sira or ano yung pinaka-damage dito sa minimal change disease natin? It is the podocytes and the shield of the negativity of the glomerular membrane barrier. Okay? Now, minimal change disease is said to be idiopathic. Okay? Unknown cause ang etiology ng ating minimal change disease. It is said to be idiopathic. Okay? It is said to be idiopathic, although, okay, however, allergic reactions, okay, recent immunization, and the presence of HLA-B12 antigen is said to be associated with this disorder, your minimal change disease. Okay, again, allergic reaction, recent immunization, okay, recent immunization, and the possession of HLA-B12 antigen have been associated with this disorder. Okay, now your minimal change disease is very common among the children. Okay, very common yan among the children. And it is, the prognosis is generally good. And as for the treatment, corticosteroids may be given to the patient, okay, to minimize the inflammation. Then next, we have your focal segmental glomerulosclerosis. Okay, now in contrast now to the previously discussed renal disorder, this disorder affects only certain numbers. Okay, it affects only certain numbers. Okay, certain numbers and certain areas of the glomerulus. Okay, of the glomeruli. Okay, kaya focal, okay, because the damage is concentrated only to certain area and number of glomeruli. Okay, while the other structure of the glomerulus remain normal. Okay, that is why it is called as focal segmental glomerulosclerosis. Okay, now the cause of damage, it is mainly due to deposition. Again, it is mainly due to deposition of immune complexes, specifically of those of IgG and complement C3 type. Okay? The cause of damage is mainly due to the deposition of immune complexes, particularly of the IgM type and complement C3. Okay? Now, for focal segmental glomerulosclerosis, okay, the symptoms, okay, is very similar with those of nephrotic syndrome. Halos pareho sila ng sintomas, okay, with your nephrotic syndrome and minimal change disease, okay. Your focal segmental glomerulosclerosis, the symptoms of this disorder is very similar with the findings on your nephrotic syndrome and minimal change disease. Okay? As with your laboratory findings, the laboratory findings of focal segmental glomerulosclerosis, okay, includes moderate to heavy proteinuria and microscopic hematuria. Okay? The laboratory findings of your focal segmental glomerulosclerosis include moderate to heavy proteinuria together with microscopic hematuria. Okay? Now, your focal segmental glomerulosclerosis, it is often associated with the abuse of heroin abuse, drug abuse, okay? Specifically heroin and analgesics, and it is often associated with acquired immunodeficiency syndrome. Okay? And then next, we have your nephrotic syndrome. This would be the last topic for today. Okay? Your nephrotic syndrome is a complication of circulatory disruption. It is a complication of circulatory disruption. Okay? Again, nephrotic syndrome is a complication of circulatory disruption producing systemic shock. Okay? Producing systemic shock. Now, kapag merong systemic shock, anong mangyayari? There would be a decrease in blood pressure, blood flow. Ang result niyan or ang ending niyan, ang affected siyan is of course, okay, one organ would be affected is of course your kidneys. Okay? Okay? There would be a decreased blood supply to the kidneys or yung tinatawag nating blood perfusion. Okay, decrease blood perfusion going to the kidney, mawawalan ng blood flow dun sa kidneys natin. Ang result niyan, it would cause damage to the kidneys. Okay? Now, in some cases, progression to nephrotic syndrome may also occur as a complication of the previously discussed renal disorder. Okay? Diba? Paulit-ulit tayo. Yung mga minention natin earlier na renal disorder, pwede yan mag-progress into, number 1, pwede yan mag-progress into chronic renal disorder, chronic glomerulonephritis, renal failure, or nephrotic syndrome. Okay? So, we can say that your nephrotic syndrome is a complication of circulatory disruption, or it could be a complication of another type of renal disorder. Okay? Now, let us go over first with the findings, hallmark findings of your nephrotic syndrome. Okay? Hallmark findings include, okay, hallmark findings of nephrotic syndrome includes massive proteinuria, usually proteinuria na umaabot ng greater than 3.5 grams per day, massive proteinuria, low levels of serum albumin, okay, high levels of serum lipids, okay, what else? And pronounced edema. Nagkakaroon ng edema ang patient natin. Okay? Pronounced edema. Okay? So, the hallmark findings of nephrotic syndrome includes massive proteinuria, usually greater than 3.5 grams per day, low levels of serum albumin, high levels of serum lipid, and pronounced edema. Okay? Now, what would be the pathophysiology of your nephrotic syndrome? Or ano yung pinaka-cause of damage? Okay? What is the primary cause of damage? Cause of damage in nephrotic syndrome. Okay? The primary cause of damage in your nephrotic syndrome, it is due to an increased permeability, yun ang key term natin doon, increased permeability of the glomerular membrane. Okay. The increased permeability of the glomerular membrane is attributed to the damage to the shield of negativity. Again, pag nagkaroon na increased permeability, yung glomerular basement membrane natin, ang result niya na madadamage would be the podocyte. Okay, would be the podocytes, and affected na rin yung shield of negativity natin ng glomerulus. Okay, shield of negativity. Okay, so there would be damage to the podocytes together with the shield of negativity, producing now less tightly connected barrier. Okay, less tightly. Kumbaga, there would be a loss of integrity of this membrane barriers. Okay. Now, such damage, kapag nagkaroon na ng damage sa mga yan, the overall damage will now facilitate the passage of different molecular substances. Okay? Such damage will now facilitate the passage of different molecular substances. Okay? So, for example, imagine niyo this is the barrier, the membrane, glomerular basement membrane. Okay? Now, dahil lumuwag na yan, increased permeability, okay? Nasira na rin yung podocytes natin together with the shield of negativity. Again, ano yung protein na yun, class, na nagre-repel sa glomerular basement membrane natin due to the shield of negativity? It is your negatively charged protein, your albumin. Okay? Now, dahil nawala na yung shield of negativity, madali nang makakalabas madali nang makakalabas ang albumin natin. Aside from your albumin, makakalabas na rin yung mga high molecular weight proteins natin, including your complement, your coagulation proteins, Okay? Your coagulation proteins, what else? Your immunoglobulins, and etc. Okay? Aside from this one, makakalabas din ang lipids natin. Okay? That is exactly the reason why kapag may nephrotic syndrome, yung mga urinary sediments na usually nakikita natin, it is mostly of those lipid-containing what do you call that? Lipid types of urinary sediment like your cholesterol crystal, your fat droplet, and etc. Okay? Now, you might be wondering sa nephrotic syndrome natin, bakit kaya tumataas ang lipid sa serum and even sa urine ng patient kapag may nephrotic syndrome? Diba? Sabi natin kanina, classic findings of nephrotic syndrome is decrease albumin and then increase lipid. Okay? Ayusin lang natin yung board. Okay? A classic chemistry finding of your nephrotic syndrome is an increased serum lipids. Okay, yung serum ang tinutukoy ko dito and a decreased albumin. Bakit kaya sa nephrotic syndrome? Okay, remember in your, again, as I mentioned earlier, that this renal disorder is a complication of circulatory disruption resulting to systemic shock. Okay? Now, ang nangyayari kasi class, kapag nagkakaroon ng systemic shock or circulatory disruption, ang pinakaunang bababa ang pinakaunang bababa sa circulation natin would be your protein, particularly your albumin. Okay? So, your albumin would be the primary protein depleted from the circulation in cases of systemic shock. Okay? Okay, overall, ang result niyan, yung nephrotic syndrome natin, or rather, yung pinaka-cause of, or pinaka-culprit natin, which is your systemic shock, ang pinaka-result niyan is magkakaroon ng hypoalbuminemia. Okay? It would result into hypoalbuminemia kasi, again, as sabi natin, albumin would be the primary protein that would be depleted in cases of circulatory disruption. Okay? Now, kapag may hypoalbuminemia, okay, pag may hypoalbuminemia class, ang tendency niyan, the liver will try to, for example, huwag ko na i-drawing, okay, the liver would try to compensate by stimulating the production of lipid. Okay, magko-compensate ang liver natin, it will compensate to the loss of protein by producing excessive amounts of lipid. Okay? Magpuproduce siya ng lipids. Okay? It will stimulate the production of lipids to compensate to the loss of this albumin. Okay? Okay. So, yun ang reason why bakit tumataas ang lipid in cases of nephrotic syndrome, because ang pinaka-problem dyan is nag-start kay hypoalbuminemia. The liver compensates to the loss of albumin by stimulating the production of lipids. Okay? Now, again, you might be again wondering why is the patient manifesting edema, or rather, bakit nagiging edema to sa patient pag sinabing nephrotic syndrome? Again, balikan nyo class si albumin. Balikan natin si albumin class kasi siya yung parang pinaka bumaba sa circulation natin this time. Okay? Again, you recall the function, the importance of your albumin. The importance of your albumin, okay, contributes to the oncotic pressure. Okay, it maintains the oncotic pressure in the capillaries. Okay, di ba tama? Okay, it maintains the oncotic pressure in the capillaries. Now, kapag nawala yan or bumaba ang albumin natin sa circulation, there would be a loss of integrity of these capillaries. Okay? There would be a loss of integrity of these capillaries, leading now to the loss of fluid. Okay? Loss of fluid. Saan mapupunta yung fluid na yan? Okay, it will now go to the interstitial spaces. It will go go to the interstitial spaces. Interstitial spaces. And then, yung fluid na yan, class, it will now proceed to the interstitial spaces. And then, this is usually accompanied kasi by sodium retention. Diba? Where water go, or rather, where water goes, sodium will follow. Okay? Kaya, nagkakaroon ng water retention. Kaya, nagiging edematous ang patient natin. Okay? Now, another complication of nephrotic syndrome would be coagulation disorders, immunodeficiency. Kasi bakit? Kasi yung mga high molecular weight proteins natin, yung mga sinabi ko kanina, your coagulation proteins, immunoglobulins, sasama din yan na mapapass out sa urine. Okay, causing now secondary complications like bleeding disorders, what else? Immunodeficiencies. Okay. Okay, now the urinalysis findings. What would be the urinalysis findings of your nephrotic syndrome? Okay, urinalysis findings include marked proteinuria. Okay, marked proteinuria, heavy proteinuria. Okay, fat droplets, the presence of fat droplets also. Okay, oval fat bodies. Okay, cholesterol crystals. And various types of cast like epithelial cell cast, fatty cast, waxy cast, and etc. Okay, and then the presence of RTE cells also. Okay, then you may also find microscopic hematuria in nephrotic syndrome. Okay, so these are the classic laboratory findings in nephrotic syndrome.